Hello. Before we begin, I would like to acknowledge that UBC Okanagan is situated on the traditional, ancestral, and unceded territory of the Silks Okanagan Nation. I would also like to acknowledge that you are joining us today from many places, potentially near and afar, and acknowledge the traditional owners and caretakers of those lands. Welcome. Before we get underway, I would like to identify a few Zoom features if you have yet to become familiar with them. Closed captioning, to turn it off, you select the hide caption button on the menu bar. With this webinar, if you have questions, please type the questions or your comments for the speaker into the chat box during the presentation, and questions will be read at the end of the presentation and answered by our speaker today, Dr. Paul van Donkelaar. Feedback for this event will also follow the event via a survey through email, and we really encourage you to take the time to fill out that survey and give us information, not only on today's events, but events that you would like to see here in the future, hosted by the Institute for Healthy Living and Chronic Disease Prevention at UBC Okanagan. With that being said, it is my enormous pleasure to introduce a colleague from Health and Exercise Science, a professor in the Faculty of Health and Social Development, Dr. Paul van Donkelaar. Paul today will be presenting his research on brain injury in women experiencing intimate partner violence. Paul, over to you.
Awesome. Thank you, Jen. And thanks for the opportunity to present today. As Jen said, I'm going to chat a little bit about some of the research that we've been doing over the last 6 or 7 years on brain injury in women who are experiencing intimate partner violence. First off, a bit of a content warning. So intimate partner violence is a sensitive topic. So please look after yourself. Feel free to leave or mute at any time. And if you do feel like you need support, I encourage you to reach out to the email listed there, which is for the SOAR project that I'm going to describe today. So just some background around kind of what intimate partner violence is and how prevalent it is. So sadly, 44% of Canadian women will experience intimate partner violence in their lifetime, and the worldwide prevalence of intimate partner violence in terms of lifetime experience is around 1/3 of women. And in cases where intimate partner violence involves physical interactions, typically it involves blows to the face, head, and neck, including non-fatal strangulation, which I'll describe in some depth later. And so, as you can imagine, if there are impacts to the head, face, or neck and/or non-fatal strangulation, then brain injury is likely to result. And it's hard to get an exact number on the percentage of IPV survivors who suffer a brain injury, but studies have shown that up to 92% who have experienced physical IPV will likely suffer one or more brain injuries as a result. So just some background on brain injury. It causes an alteration in brain function that can be caused by either external forces or, in the context of intimate partner violence, a reduction in oxygen supply due to non-fatal strangulation. So concussion is another word that is used out there, is a form of brain injury that, as I mentioned, is caused by a hard blow or jolt to the head, neck, or body that causes the head and the brain to move rapidly back and forth. In the context of intimate partner violence, brain injury can also happen through non-fatal strangulation, which cuts off blood flow and oxygen supply to the brain, resulting in injury. So in episodes of physical IPV, the sorts of injury mechanisms include being punched or hit in the head with an object, kicked in the head, violently shaken, pushed downstairs, thrown out of moving vehicle. These are all things that participants who've been involved in our studies have mentioned as injury mechanisms. And then non-fatal strangulation, which occurs in nearly half of survivors of physical intimate partner violence. Brain injury in general, independent of the injury mechanism, can lead to a number of signs and symptoms. I've listed a few here. So headaches is one of the key ones that typically will occur. Fatigue, dizziness, difficulty with memory or concentration, challenges around sleeping, certain emotional dysregulation, so worries and fears, depression, sadness, anger, and then sensitivity to sensory stimulation like noise and light. In the context of brain injury due to intimate partner violence, these signs and symptoms may lead a survivor to be easily distracted, to have difficulty following instructions, to forget appointments or chores if they're at a women's shelters, for example, to be tired or fatigued or irritated easily, and have issues adapting to their changing context. And so these are all things that are quite common in survivors of intimate partner violence, but up until recently haven't necessarily been linked to the possibility that a brain injury may be contributing to these challenges. So in response to this kind of context, together with my partner, Karen Mason, who at the time was the executive director of the Kelowna Women's Shelter, we launched a project called SOAR. And SOAR is a loose acronym for Supporting Survivors of Abuse and Brain Injury Through Research. So it's a community-engaged, multidisciplinary research initiative. We launched it about 9 years ago now, and it's a collaboration between my lab at UBCO Okanagan and Kelowna Women's Shelter. And we subsequently engaged with a number of other women-serving community organizations, both in the Okanagan and throughout the province. It now, as of earlier this year, is a nonprofit charitable organization that Karen is leading and I am the scientific advisor to. So it's got three main goals. The first is to explore, and most of the talk today, I'll focus on this aspect, because that's really the scientific background of our attempts to characterize the incidence and effects of brain injury due to intimate partner violence. A second main component is around educating those who work in various sectors that provide support for survivors so that they are more aware of the fact that brain injury may be experienced by the clients they serve. And then a third component that I won't talk about in any detail today, but I'm happy to answer questions around, is to create better awareness and support services for survivors themselves. So creating an ecosystem in which they feel supported and hopefully can move on from a life that's free from abuse. So in terms of characterizing the incidence and effects of brain injury from intimate partner violence, we've taken kind of two approaches. The first is to kind of model what we do in research on brain injury from other injury mechanisms like sport-related concussion, and that's to look at people as soon as possible after the injury, so within 1 week of the incident itself. And our initial foray into doing this involved a collaboration with the Embrace Clinic, which is in the Fraser Health Authority. And it's one of Canada's only specialized clinics for survivors of sexual violence and intimate partner violence. And so they typically get clients referred to them from the emergency room at Surrey Memorial Hospital and will see most of their clients, like I say, within 1 week of the incident. And so for this initial acute phase study, what we did was an analysis of evidence consistent with a brain injury from the forensic nurse examiner chart that they go through with their clients. So we analyzed the narrative and details of the survivors' responses in those intake forms to get a better sense of what percentage of their clients were experiencing potential brain injury. A large proportion of the work that we've done up until now is more around the chronic phase of IPV-related brain injury. So this is months to years after one or more previous incidents of intimate partner violence that likely resulted in a brain injury. And so this involves recruitments of clients from various women-serving community organizations like Kelowna Women's Shelter. And we do a variety of assessments directly with those participants, including assessments of post-traumatic stress disorder, anxiety, depression, trauma history, substance use, self-reported history of potential brain injury resulting from intimate partner violence, as well as lab-based assessments of neurocognitive and cerebral vascular function. So this is the first paper that came out earlier or last year on the acute phase by our team. And here's kind of the main results of that was just kind of, again, characterizing what we were seeing in those intake charts. And so this first table just talks about the mechanism of injury. And you can see that many of the things that were described by the clients in basically explaining what happened to them, are potential injury mechanisms for the brain. So pushing, slapping, strangulation, punching, kicking, these are all things that could potentially result in a brain injury. And you can see that they happen a lot in these participants. And it's important to note that those categories are not mutually exclusive. And that's kind of a common theme in a lot of this research, is that those injury mechanisms tend to be multiple in origin and include both head impacts and typically both include head impacts and non-fatal strangulation. So these intake forms ask explicit questions about what were the injury mechanisms, and the clients responded, describing what had happened to them as best they could. And then in the narrative, although it didn't explicitly ask about signs and symptoms of potential brain injury, so it was really just the clients endorsing or disclosing in their descriptions of what happened to them, what some of the things were that they were feeling afterwards. And so you can see that we've broken them down into multiple categories here, all that are consistent with a potential brain injury, loss of consciousness being a really obvious one. And in those participants who did disclose symptoms, about 30% had symptoms that were consistent with brain injury. So even though they weren't being asked explicitly about brain injury symptoms, they endorsed or described signs and symptoms that were consistent in a large proportion of cases with a brain injury. And so at this initial effort to look at the acute phase of IPV-related brain injury showed clear direct evidence that strangulation was occurring relatively frequently. And if strangulation did occur, I didn't show this in the tables, but participants were over 2 times more likely to report injury symptoms. And those brain injury symptoms were disclosed in about 31% of the cases, despite not being directly asked about it. And so one of the things that the Embrace Clinic has done in response to these findings is to adapt their intake forms to more explicitly ask about potential brain injury symptoms in their clients. In terms of the chronic phase, we've had a few papers published over the last few years, and that the number is expanding all the time. So it's wonderful to see more and more research on this, not just from our lab, but from other researchers across North America. And so what we do in these chronic phase experiments is we recruit from these community organizations. We have an initial session where we go through all the questionnaires related to the psychopathological comorbidities, so things like PTSD, anxiety, and depression. And then we have a subsequent session where we bring them up to the lab and we do assessments of neurocognitive function, brain blood flow, and do some blood draws to look for blood biomarkers consistent with brain injury. And I should mention that the reason that we do all of these other assessments of the comorbid factors is that they can all have an impact on aspects of brain function that can mimic or mirror or look like what happens in brain injury. And so it's important to try and disentangle the contributions of the potential brain injury itself versus the comorbid factors that can also have an impact. And one of the key tools that we use is called the Brain Injury Severity Assessment Tool that was developed by one of the pioneers in this research area, Dr. Eve Valera from Harvard University. And so it's a kind of semi-structured interview where it's a series of questions related to the intimate partner violence incidents with the partner that resulted in brain injury signs and symptoms. And so it could be a question, typical question would be, after something that your partner did to you, did you feel dizzy afterwards, or did you have difficulty concentrating afterwards? And if the participant answers yes, then there's follow-up questions around how frequently it happened, when was the first time, when was the last time. There's explicit questions around the severity of the potential brain injury. So did they lose consciousness or experience a period of post-traumatic amnesia? And then how long did those signs or symptoms last? And it results in a score from 0 to 8. So 0 means that either they didn't experience any physical intimate partner violence, so it was other forms of intimate partner violence, mainly psychological and emotional, or if they did experience physical intimate partner violence, it was directed to some other part of their body. And then on the other extreme, a score of 8 means that they experienced physical intimate partner violence. The head, face, or neck was quite often targeted, and it happened very frequently. The most recent episode may have only been a short period of time ago, say a few weeks, and or it resulted in loss of consciousness or a period of post-traumatic amnesia. And so you get this range of scores, including, importantly, a score of 0, which is a great control group because it means they've experienced all of the kind of comorbid factors associated with intimate partner violence without the actual injury mechanism to the brain itself. So just some preliminary information on what we found when we used the BISA. So this is all of the participants in the initial cohort that we studied, about 70 participants. And what I've done here is just plot the distribution across the different scores, as well as indicated whether they had experienced non-fatal strangulation or not. And what you can see is that there's a nice kind of normal distribution, more or less. Sadly, not very many people scored 0, so only 4 participants out of the 70 or so. Most were kind of in the middle, the 2 to 5 range, and then the numbers decreased as it got up to the more extreme. The other thing, pardon me, that you can notice is that strangulation, if it did occur, was associated with higher BISA scores. So if they experienced non-fatal strangulation, it tended to be in more severe instances as reflected in higher BISA scores. And in fact, when we did a simple statistical analysis, we found that if they had experienced episodes of strangulation, the more they had experienced, the higher the BISA score. Next, we looked at how our IPV participants compared to young athletes who had experienced a sport-related concussion. So my lab has historically done work in sport-related concussion and continues to do a bit to this day. And so we could do those comparisons because we had data that we from the young athletes. And so this is from an assessment of the number of symptoms that they were currently experiencing from a tool that's used to assess a sport-related concussion. And we can see in young athletes, before a season of collision sports like hockey or football, they would endorse a small number of symptoms in an otherwise healthy state. But then within a few days after experiencing a sport-related concussion, the number of symptoms goes way up, which is kind of a classic sign that concussion has likely occurred. So this is within a few days after the injury has happened. In our IPV participants, you can see that the number of symptoms that they endorsed are at the same level or even higher than the young athletes at the acute post-concussion stage. And it's important to note that these are all participants who we measured chronically. And so I think the earliest we saw someone after their most recent episode was a month or 2, and many of them were a year or more post most recent episode. The point being that these are chronic symptoms that people are experiencing. Down here in this graph below, what we've are showing is the number of symptoms as assessed using that sport concussion assessment tool relative to the BISA score, just to show that they're kind of tapping into the same thing. And what you can see is there's a strong positive correlation between the two. So if a participant scored low on the BISA score, they tended to have a fewer number of chronic symptoms compared to participants who scored high on the BISA score. And in this table on the right, what we're showing is kind of the correlation between each of these symptoms that participants endorsed and the BISA score itself, broken down by these different symptoms. And people who are experiencing potential brain injury from intimate partner violence have all sorts of symptoms that are consistent with brain injury. And so this is, again, fairly clear evidence that something's going on and brain injury is likely contributing to it. So we attempted to assess this in the lab in a number of different ways. So the first that I want to share is making use of this fancy piece of equipment called a kin arm, which allows us to gain access to a number of different kind of cognitive and sensory motor functions. And the main task that we used in the participants with intimate partner violence was called the object hit and avoid task. So as the name implies, participants are using the KinArm device to hit virtual targets and avoid non-targets. And so I've got a short segment of video here to give you a sense of what was going on in the task. It's kind of like a really expensive version of Space Invaders, if you remember that video game from the 1980s. So I think in this example, they're meant to hit the elongated rectangles and the circles and avoid the other shapes. So we'll see how this participant does. So you can see they do fairly well at avoiding the non-targets and hitting the targets. The task, this is just a short segment of an example of this task. The way the task progresses is as time goes by over the course of several minutes, the targets start falling down from the top of the screen at higher and higher speeds. And so as you can imagine, it gets harder and harder to hit the targets and avoid the non-targets. And so we can make all sorts of measurements of how accurate they were, how fast they were, and how successful they were at following those rules. And so when we plot a couple of these variables, so total targets hit and average hand speed, which are proxies for how well a person did, and plotted these two dependent variables against the BISA score, we got significant negative correlations, showing that if people had fairly low BISA scores, they tended to hit more targets and move their hand more quickly, whereas if they had relatively high BISA scores, they tended to hit fewer targets and move more slowly. And the one thing that I mentioned that, we also PTSD, depression, and anxiety. And so we did a much more complex statistical analysis, basically using multiple regression analysis to tease apart how much of these changes relative to potential brain injury or were due to potential brain injury as opposed to some of these other factors, and found that the brain injury contributed significantly to many of the dependent variables that we looked at, but that things like PTSD, depression, and anxiety also contributed to some of the variation that we saw in these dependent variables. The kind of take-home message there is that it's not all brain injury, and certainly some of the psychopathological comorbid factors absolutely contribute. And so it's this complex interaction between the physical injury to the brain and the kind of psychological impacts of going through this experience of intimate partner violence. The next thing we looked at that I want to talk about is cerebrovascular function. So this is, blood flow to the brain. So we published this article earlier this year examining that. And so we use a technique called transcranial Doppler ultrasound to measure cerebral blood flow. And what's shown kind of in the left part here are kind of average traces for the people who scored low on the BISA. So I think it was from 0 to 4. And then below that on the top trace here, people who scored high on the BISA, so 5 to 8. And so what I'm plotting here are basically the relative blood flow velocity in the posterior part of the brain, in the middle part of the brain, and then the mean arterial pressure to show that blood pressure changes in blood pressure weren't systematically contributing to the potential changes we saw in the brain blood flow. And so what the main finding that we found was that in the posterior part of the brain, which was involved in this task that the person was doing, involving a complex visual discrimination task, the brain blood flow was significantly lower at baseline and at peak in participants who scored higher on the BISA, i.e. had more exposure to potential brain injury from intimate partner violence. And this is captured in a number of different dependent variables that we looked at, including the baseline, the peak, and the percentage increase in the blood flow was significantly lower for each of these dependent variables in those who scored higher on the BISA score. And this is probably the most complex set of figures, but it's, I think, a really interesting aspect of what we're doing in this project. So we're measuring a lot of different things. I've mentioned kind of cognitive sensory motor behavior, cerebral blood flow. I also talked briefly about the fact that we're doing blood draws to look at blood biomarkers for brain injury. So what I've plotted here are three different variables from the cerebral blood flow measurements, plotted against one of the blood biomarkers that we've been able to analyze so far in our initial data, which is a blood biomarker called TNF-alpha, which is a pro-inflammatory biomarker. So the higher a TNF-alpha level in the blood, the implication is that there's more neuroinflammation in the brain. And remember, this is all in the chronic phase. So these are all folks who have experienced multiple brain injuries from intimate partner violence over the course of months or years, and we're measuring them sometimes months or years after their most recent episode. So it's all chronic changes in their physiology and pathophysiology. And so what we found is that there's a fairly strong negative correlation between the levels of this pro-inflammatory biomarker and changes in the brain blood flow. So people who had higher levels of neuroinflammation tended to have lower baselines, lower peaks, and lower areas under the curve. Kind of a third dimension to these graphs is the color. And so the color here represents basically the level of the BISA score, the magnitude of the BISA score, with cooler colors meaning lower BISA scores and hotter colors, the yellows and oranges and reds, meaning higher BISA scores. And we haven't done any kind of statistical analysis of this. It's more just kind of the feel of things. But the tendency, at least when I look at these graphs, is that the cooler colors tend to be on the left-hand side of each graph, sorry, the right-hand side of each graph, and the hotter colors tend to be on the left-hand side of each graph. And so that implies that the association between the pro-inflammatory biomarker TNF-alpha and the cerebral vascular variables co-varies with the amount of exposure to potential brain injury from intimate partner violence. And so IPV-related brain injury, therefore, appears to be linked to both chronic neuroinflammation and reduced cerebrovascular function, which has all sorts of implications for kind of development of longer-term neurodegenerative processes. So in terms of the chronic phase, what we found is that the majority of the participants, 92% out of that initial cohort, had experienced at least one intimate partner violence-related brain injury. Those who had experienced non-fatal strangulation tended to have higher BISA scores. I didn't mention this when I was going through the initial data with the BISA, but Indigenous women were overrepresented in the population, and that's confirms what has been shown previously for intimate partner violence generally, is that Indigenous women and marginalized folks in general tend to experience intimate partner violence at higher rates than non-Indigenous women or folks who aren't marginalized. The number of symptoms that we were able to glean from the participants of IPV tended to be greater than that observed in acute sport-related concussion, even though this was being measured at the chronic time point. They had a reduced ability to make these fast coordinated movements that involve kind of cognitive processes associated with attention and executive function. And there was altered cerebral blood flow that was associated with a biomarker for neuroinflammation. So literally the bottom line is that in IPV, at least physical IPV, people are experiencing repeated brain injuries that result in chronic symptoms that have long-term consequences. So that's the kind of science data side of the story. Kind of the next big question around all of this is, well, what do we do about it? How can we better support survivors? And so this is kind of the educate piece of what we do through the SOAR project. And so we identified fairly early on that people who work at women's shelters, who are quite often the first line of defense or the first point of contact for people who've experienced intimate partner violence, don't know very much about the connection or the interaction between brain injury and intimate partner violence. And so we created a module of this tool called the Concussion Awareness Training Tool, which has been developed initially in the context of sport-related concussion, but subsequently has expanded to a number of different sectors or a number of different, I guess, folks who could be affected by or influence if someone has experienced a brain injury in terms of providing support. And so we added a module called the Women's Support Worker module that puts brain injury into the context of intimate partner violence and how people who work at women's shelters could better provide support for survivors when they show up at the doors of the women's shelter. And so it's fairly straightforward. It's about a 30 or 40-minute training course, kind of video and text base. It's available in both English and French. It has a series of brief quizzes throughout so that a person can make sure that they're aware of some of the things and have more knowledge of the brain injury and intimate partner violence. And then the person gets a certificate out the other end. It's been, and we've had, I think, close to 2,000 people taking it. And I encourage you, I mean, even though it's pitched as something that people who work at women's shelters should take, it's pitched at a level that's, I think, understandable for anyone. And so if you're interested to learn more, I encourage you to take it. It's completely free and easy to undertake. This is a paper where we basically described our evaluation of the effectiveness of it. And so we showed that people who took the course knew more after the course about the potential intersection between brain injury and intimate partner violence. They knew kind of the signs and symptoms and the red flags to identify. And in kind of one-on-one interviews with women's shelter workers, one of the key things that came out is they felt more confident in terms of advocating on behalf of their clients to get more support and to accommodate for the fact that many of their clients likely had a brain injury. So we feel like it's had some impact, at least in the context of women's shelters workers. SOAR has been really proactive about creating more knowledge and doing integrated knowledge translation out into the community. And so we've created a number of resources, including brochures and kind of a simple assessment tool or adapted version of an assessment tool called the HELPS tool to help mainly people who work at women's shelters to better support survivors. But again, kind of these are available for anyone, completely free, and I think can help raise knowledge and awareness of this intersection in the general public as well. We are not the only people doing this. We've got some great colleagues at the University of Toronto who've developed the Abused and Brain Injured Toolkit website that is a much more in-depth dive into this intersection and all the evidence and knowledge and information that's out there and available. So it's a great resource if you really want to learn in a lot of detail what this intersection is all about. There are a number of books out there, and this is one that we always recommend. It's probably about 4 or 5 years old now, but Rachel Louise Snyder wrote this book a few years ago, and it's about intimate partner violence in general, but it does incorporate some aspects of potential brain injury from head impacts and non-fatal strangulation. So if you're interested in reading an accessible but in-depth book about this topic, I highly recommend that. Finally, I'd just like to thank the funders who supported this work. We've been very fortunate over the last 7 or 8 years to be able to get some fairly substantial funding through a variety of funding mechanisms to support the work. Most of this funding goes to trainees who are the main people who do all of the studies, and so grateful to them to be able to contribute to their learning and education and learn a little bit myself along the way. This topic is also very multidisciplinary. So, you know, I'm a neuroscientist by training. I know a little bit about how the brain works, but intimate partner violence is a very broad topic. And so I've been fortunate to collaborate with a number of colleagues, both at UBCO Okanagan and elsewhere, to try to better understand all of those different components that contribute to this intersection between brain injury and intimate partner violence. And so none of this work would be possible without those folks. And with that, I think I'll stop. I'm not sure how I'm doing on time. Thank you for your attention. Here's some places where you can get in touch or learn a little bit more about the project, and I'm happy to answer any questions you might have at this time.
Thank you, Paul. Thank you for both the work you're doing and for sharing it with us today. I'm grateful that you took the time to do this and acknowledged, especially in the beginning, for individuals to take care of themselves. So thank you for that. And I'm going to reiterate that as we move forward into the question and answer period. If you need a moment, please take a moment. And if you need to reach out afterwards, the information is on the slide, and I'll ask Jaquetta to see if she can put it in the chat box as well, please. So with that being said, Paul, early in the presentation, there was a question. The question from Maha reads, what happens when they don't remember details to answer the questions, which must be the case for many?
Yes, yeah, it's a great question. And it's the biggest challenge in a lot of this work, especially in the chronic phase where we're asking them questions about things that may have happened years ago. And so, in the most extreme case, if they lost consciousness or they have post-traumatic amnesia, by definition, they won't necessarily remember at least those moments where they were not conscious or having trouble remembering. And certainly that's, not just going to end and then all of a sudden they're going to remember everything after half an hour or something. And so, yeah, you absolutely have to live with the fact that some participants won't remember all of those details, and it's just it's a imperfect science, I guess. And it opens up the broader question of, how can we be sure that brain injuries actually happened to these people? Because in the ideal case, so let's say sport-related concussion, right? A young hockey player gets hit into the boards, smashes their head against the boards, and then on the ice, there's other players, there's coaches, hopefully there's someone with a little bit of medical training, there's people in the stands, there's potentially hundreds of witnesses, right? Who some of whom may have some clinical
Very good.
training. Sorry if I froze there, but is talking about this, the difference between a sport-related concussion where the injury mechanism is witnessed. Hopefully there's someone with a little bit of clinical training to be able to do some assessment within minutes or even shorter after that injury occurs. And then hopefully make a good decision, right? Either they suspect that they've had a concussion, so they're probably okay to continue, or they suspect that they have had a concussion, and then they pull them out of the game and get them to some medical care fairly quickly. None of that is there in intimate partner violence. The only witness is the person perpetrating, maybe the children, but it's nowhere near as clear cut as what we see in intimate partner violence. And so you have to rely on the person's self-report. And that's open to bias. And so again, it's just something that we live with in this context. And it's part of the motivation for starting to try to do the work at the more acute and subacute phase, where some of the assessments we do are pretty much the exact same thing we do in sport-related concussion and brain injury and other injury mechanisms. And so we'll be able to draw much more clear comparisons than what we currently are able to do with the chronic context.
Thank you. I think it's also, you acknowledged witnesses. Video is another one that's prime in many public places, but in your home, although it is becoming a little bit available, I don't know if
Right.
it's available in the context of what you're talking here. So you're so right that the presence and the visibility of it is so different. So thank you for reminding us of that. Claire has a question. It's more of a general brain injury question. Do you know of a program or a subsidy in BC providing funding or incentive to employers to hire those living with brain injury? Could be an important resource for survivors who want to be honest about their symptoms
Yeah.
and face a lot of stigma in returning to work.
Yeah, it's a great question as well. I don't know specific details. I do know that there are supports for folks who are wanting to return to the workplace, while still experiencing potentially chronic effects of a brain injury. And you're absolutely right. That same sort of support needs to be there in the context of intimate partner violence. And I think, as you mentioned in your question, right, there's a lot of stigma around this experience that tends to not be there, or certainly there to a much smaller degree, in other brain injury mechanisms like sport-related concussion. And so a lot of the kind of knowledge and awareness raising work that we and others are doing is around trying to reduce those barriers and reduce that stigma and be more open about this is happening, and here are some of the impacts of it happening, and how can we accommodate people who are going through this in a variety of ways, including accommodating around potential brain injury. So thanks for that question, and I'm sorry I don't have more detailed information to help answer it, but that's the gist of I think the current context and the work that continues to need to be done around intimate partner violence.
Thank you. I'm going to encourage, if there's questions, please place them in the chat and they'll be read out. Paul, I am curious, in the material that you've presented today and the research that you've done, is there an influence of things like age or maybe elements of neurodiversity, or if we look at sex and gender and even transgender, different aspects, how is that mixed in, if you will, with brain injury and intimate partner violence?
How much time do you have? Um,
In about 11 minutes.
Okay. So absolutely, again, I keep on going back to other brain injury mechanisms. So we know, again, from mainly sport-related concussion work, that kind of pre-existing conditions absolutely have an impact on how a person recovers. Given the same kind of injury mechanism and severity of that injury mechanism, folks who have, mental health challenges, for example, or learning disorders or ADHD, prior to the injury, tend to take longer to recover. And so certainly in the context of intimate partner violence, many of those things are there quite often as a result of the intimate partner violence. And so it gets to this kind of complexity of the interaction between these different factors and how to account for them. Age is the second one, right? So we're just starting to look at this as well. There's a couple of recent studies that are in the pipeline from both our team and from others that are kind of looking at the longer term impacts and kind of what happens to a person when they're in the kind of 20 to 40 age range in terms of subsequent mental health in particular, and overall functioning when they get to be 50, 60, 70. And kind of initial results suggest, maybe not surprisingly, that those that go through this experience and have more exposure to potential brain injury from intimate partner violence tend to have kind of reduced, what's the word I'm looking for? More negative mental health outcomes in the longer run. And maybe that's not that surprising. Again, to draw the analogy to collision sport athletes, it's been known for a long time now that there's some sort of link between how much exposure to head impacts you've had playing football or hockey and longer term neurodegenerative processes, the big one being chronic traumatic encephalopathy. And so there are some initial studies looking at neuropathological outcomes in folks who've experienced intimate partner violence and potential brain injury and have subsequently died, and looking at some of the potential markers for CTE in those participants. And the jury's still out. We don't know for sure, but it looks like there's something going on. Whether it's CTE or something else, I think is an open question. Sex and gender minority individuals is the third part of your question. So I have a PhD student currently, Tori Stranges, who's working exactly on this question. And kind of her initial results are that sex and gender minority individuals are more likely to experience intimate partner violence for a variety of reasons. And brain injury is absolutely part of that mix. So her initial results, so at least in a survey study, that participants, sex and gender minority individuals who had experienced intimate partner violence, about 67% of them, at least who responded to the survey, had signs or symptoms that were consistent with a brain injury, which is a little bit bigger than what we see in folks who aren't in sex and gender minority. And so it's consistent with this, this kind of idea that, intimate partner violence affects everyone. It doesn't discriminate, more or less. And brain injury is absolutely part of the mix. But those that are marginalized in one form or another, or from an intersectional perspective, are much more likely to term impact.
You froze, Paul.
system works. Sorry, did I freeze?
You did freeze, yeah. Right after intersectionality. And I think you're frozen again.
I just realized I was frozen. I don't know how far I got. But the point is that folks who experience marginalization are more likely to have longer term impacts, and I guess those impacts are more likely to have an effect on their life. Um, and so, some of that is probably not necessarily due to intimate partner violence and brain injury. It's due to the fact that they're in this category of folks that are marginalized for one reason or another, and the system isn't set up to support them appropriately.
Thank you. It's complex and it's also sad.
Mhm.
There's 3 questions currently sitting in the chat. I think we'll be able to get to them before we finish up on the hour. So the next question is, oh, maybe there's 4 because my screen just moved. Thank you for an impactful presentation. My question, have you explored the impact of the incidents on the future generation involved in the incident?
Yes, I mean, we haven't. There's absolutely, research on what is the impact of children who witness uh, intimate partner violence, and the kind of intergenerational trauma that comes along with that, and absolutely it occurs. So children who've witnessed intimate partner violence at a young age are more likely to grow up to either experience or perpetrate intimate partner violence themselves. So that being in that context and experiencing what's going on with the adults in your household as a child has an impact on how you interact with potential partners down the road as a young adult. The lab did just do a systematic review that's being considered for publication on physical intimate partner violence around pregnancy, so in the perinatal period. And sadly, it's relatively prevalent and common. And so there are no studies that have looked at potential brain injury in the perinatal period. Let me back up. There are studies on intimate partner violence in the perinatal period in terms of the effect on the unborn fetus and the development once the child is born. And as you can imagine, it's not positive. So there are absolutely negative impacts of experiencing physical intimate partner violence while pregnant on the child. And there are no studies yet on how brain injury may potentially play into that. But given what we know about physical intimate partner violence in general, and the fact that it results or is consistent with a brain injury occurring, it wouldn't be surprising if it's also occurring in pregnant individuals, and all of the impacts and consequences of that, both on the mom as well as the child, are likely there. But studies still need to be done.
Thank you. The next question is, knowing there is evidence to suggest that brain injury and symptoms are occurring in these women, what can we be doing at a systemic level to help facilitate easier transitioning out of abusive relationships into shelters and further? For example, if women are experiencing memory deficits or chronic pain, are the systems in place sufficient to help them out of these situations on top of dealing with the brain injury symptoms?
Yeah, no is the short answer. And a lot of this work we're doing around raising knowledge and awareness is around trying to change behaviors, or at least having folks who work in these various sectors and systems that provide support be more aware of the fact that brain injury is likely having an influence on the client that's sitting in front of them, and how better to interact with them and provide them with support so that they can be more likely to escape from abusive relationship. The stigma around intimate partner violence is for someone to leave an abusive relationship. Like, the question, well, why doesn't she just leave, is not the right question. The right question is, why does he continue to hurt her? Not to put too fine a point on it, but so it's really hard for people to leave these relationships quite often. It usually takes about 7 times attempting to leave before a person is successful. And part of the problem is, where do they go? Women's shelters have been around for a while now, but they're completely overburdened, right? Like they have to turn people away every night because they don't have enough beds. And so, clearly the various levels of government need to do something, put more money into the system to allow people to escape more easily and give them the support they need as they hopefully again transition away from an abusive relationship. It's hard. And so we hope that some of this work is contributing to those conversations and helping to create more opportunities for support to be provided.
Thanks, Paul. I recognize I missed a question and you addressed it partly in another question, but I'm going to read it in full and then you can add in any way that you feel appropriate. Could some of the damage that you have seen be a result of a child being hit around the head? Is there a link between experience of this violence in childhood going on to be a violent adult relationship?
Yeah, so I touched on it a little bit. And one thing I didn't mention is, people have measured this as directly as possible. So you can measure what is termed adverse childhood experiences, or ACEs. And we measure that now with our participants because we know that people who've gone through adverse childhood experiences are more likely to end up being in an abusive relationship, again, either as the perpetrator or the survivor. And so it's another factor that you need to take into account. And certainly, whether it's physical and or emotional abuse in childhood, those things tend to stick with you into adult life and can affect the trajectory of your life and the trajectory of your relationship with other people, including a potential intimate partner violence, that can make you more vulnerable to either perpetrating or being a victim of intimate partner violence.
Thank you, Paul. On behalf of the Institute for Healthy Living and Chronic Disease Prevention, Paul, I really want to thank you for sharing your research and your time with us today. I'd like to thank the attendees for their questions and their presence today on such a complex, emotional, cognitive, and important topic. So thank you, Paul, and thank you all for attending. And please watch for a survey to come through email later. Enjoy the remainder of your day, everyone. Thank you.
Thanks, everyone. Thanks for your opportunity to present.
Take care.